Hello and good morning. Hope everybody is okay. And thank you and welcome for this AMC Clinical High Yield session. I welcome you all. And again, I'm very thankful that you're making time to attend this free session. So currently, we've got about 64 to 65 people. I'll keep adding them on as they come on. So this is a very focused session. And what I'm trying to do in this session is that I'm going to talk about some recent high yield cases. And I'm going to take a very unique approach. Now, this session becomes highly valuable for the people who are about to take AMC clinical exams, say next 2 or 3 months. But even for the people who are planning to take the AMC clinical exam down the line after passing the AMC MCQs, and they want to just orient themselves about having a very unique approach. And I think how good it would be to have an approach oriented through the case and following a particular pattern. So firstly, let me highlight what we're going to do over the course of the next hour. So I'm going to basically discuss five very high yield cases if the time allows five. If not, then obviously we'll see how we go. And we're going to be completely task oriented because AMC Clinical is all about fulfilling the task. It's about gathering the information as per the task and giving the information again as per the task. So we're going to be completely task oriented, and that's how I've completely broken down these scenarios. I've also made particular slides for role player instruction because, it's important for you to realize what the role players are all about, what they're talking about, and what information you need to extract from them for that particular case. So there will be a role player slide as well for you to be able to understand how the information is gathered. Um, After that, we're going to discuss about the key working diagnosis and the differential diagnosis, which is, I would say, pretty much the framework of the entire clinical scenario. That when you read the clinical scenario, you decide upon the framework. This framework is exactly based on your key working diagnosis and the differentials, how to exclude. So, relevant positive and relevant negative. I hope it makes sense. We'll complete the task and we'll go through each and every task, what are the requirements, and at the end, I will basically summarize and add in the key points. And then we'll also have a checklist for every case that these are the important points which must be covered before the examiner can pass you. So let's just start. I'll start and share my slides if that's okay. Just give me a second. All right, there we go. So I hope everybody can see my slide. Wonderful. Thank you very much. Thank you. All right. Without further ado, let's just start. Okay. So look, I'm going to jump right into the case number one. And this is a case about a little boy who's 10-year-old called Michael. So Michael is a 10-year-old boy with a known diagnosis of asthma. He attends your GP clinic with his mother, Mrs. Davies, for an asthma review. Mother reports that he uses salbutamol inhaler 4 to 5 times per week, but he wakes up coughing. And that happens at least twice per week. He is prescribed fluticasone, which is also known as Flixatide, and he is using Flixatide or fluticasone on most days. Now, your tasks are assess Michael's current asthma control, review and educate the parent on asthma management, and provide communication and reassurance using quite an empathetic language. Now, I have actually emphasized this task, number three, that you need to be communicating very well. It should only be educating the parent. Okay, so let's jump right into it. So because I'm not playing role, I'll just dissect this scenario, that what is this scenario all about. So this scenario is about an uncontrolled asthma. I think everybody knows that very well. And why do we know that it's an uncontrolled asthma? Because there is a frequent reliever use. Now, when I give you the information from the role player, you will begin to appreciate that how frequently are they using. And that information would be coming from the role player. And that's the crucial information you must be gathering from the role player, because you need to prove your point. You also need to prove your point that the patient is waking up with frequent night coughs. And then obviously we need to make sure that there are no emergency department visit, there are no systemic signs of illness which might be contributing or making it worse, because it is all about current asthma which is not well controlled. Now, the other differential diagnosis, it could be because it could be inappropriate use of the preventer, it could be poor use of the inhalers, both short-acting inhalers and long-acting inhalers, and so forth. So let's move on. Okay, so this is the RCH guideline. And basically, this RCH guideline is all what it's telling you: daytime symptoms, need of reliever, limitation to activity, and nighttime symptoms on waking. So basically, if you look at it, good control, what does it mean? That daytime symptoms are less than 2 days per week. Night need for the reliever, again, less than 2 days per week. Limitation of any activity, exercise, or doing normal physical activities, swimming, football, soccer, none. And nighttime symptoms, none. Why nighttime symptoms are important? Because there's a lot of congestion of mucus, and the patients do develop nighttime symptoms, which might be an indicative of poor control of asthma. So this is a very specific indication as per RCH guideline, what you need to make sure that where this patient classifies. Partial control, which means that they are having more than 2 daytime symptoms, more than 2 days per week of nighttime symptoms. There is some limitation of activity, and there is also some nighttime symptoms. Obviously, poor control would be more than every category. So I would say at least 3 to 4 times. Also, need of reliever 3 to 4 times a week, limitation of every activity, and frequently waking up multiple times during the night time. So again, this is a very important. I'm more than happy for you to take screenshot if you want to. I don't mind at all. Let me show if see if my other tutor is here, Mr. Divij. No, he's not here. I'm not sure. I'm just going to have a quick look. What name is he using? Um, okay. So everybody okay with the slide? Yep. So let me have a look. Um, so again, this is a very, very crucial slide, which basically gives you a stepwise approach or a stepwise plan in terms of maintenance therapy with the preventer and symptomatic relief with a short-acting beta agonist, which is um, salbutamol. What is a maintenance implementer? Like, fluxetide or fluticasone or inhaled corticosteroid injection. So step one, no utilization. When we see patients most commonly in emergency department in the hospital, if they're not using any preventer, that's fine. Step two, you do add them on once a week of a low dose inhaled corticosteroids. Moderate dose, at least once, twice daily of fluticasone or fluxetide junior. Step four, which is a moderate to heavy use, at least inhaler, 2 puffs of fluxetide junior in the morning and 2 puffs at night. This is a more regular use of fluxetide inhaler. Okay. So let me just have a look once more. There's a lot of people who I cannot like enter because we're already full. So there's already 100 people in there. So I cannot really add any more people. So my apologies. But I will be releasing a video which would be, shared onto the Facebook. Okay. And symptom relief. We've got an asthma management plan with a short-term short-acting bronchodilator like salbutamol. Okay. So let's start move on. Okay. So in terms of role player instructions, the thing that you would be looking for would be quite specific. That the actor would be genuinely worried about the sleeping pattern. They would be genuinely worried about how whenever he does the exercise would be limited because of the shortness of breath. And they were saying that, look, a parent could be either parent. It could be the dad or the mother saying, Michael, who's an 11-year boy, he's using Preventer, which is Flixtide Junior on most days. They might say that the technique is not quite correct. They won't say that, but you need to extract that information, that how many puffs of Flixitide Junior are they using? One puff, how many times a week of Flixitide Junior are they using? Are the symptoms triggered by exercise? Are the symptoms triggered during the nighttime? So remember those two key issues: more than twice per week, okay, and plus during the exercise and night time. That is what will define everything. Now, assess asthma control. Ask about the reliever use, night symptoms, daytime impact, and obviously the school related activities like fatigue, unable to play soccer, swimming, or any of the other things. And determine if asthma is uncontrolled based on that chart which I showed you. Okay. Now, this was the task one. Now, task two is your obviously, task one was assess the asthma control. Task two is review the current management. So, how frequently are they using fluticasone? Reason for the missed dose. So, when you're taking the information from the role player, there would be an information that they are not using fluticasone or Flixitide Junior regularly. They've been frequently missing the dose. It could be because of the school time, and he might be also, the parent might not be supervising the dose properly. And also we need to check about the inhaler technique. So because it's a face-to-face exam, there might be an inhaler there, and you can ask the parent to show how they use the inhaler. And once they show you the poor technique, either by word, look, we are not sure, the child is doing it myself, you can link that information of non-adherence or poor technique to a poor or inadequate control. Last task was about educating and reassurance of the parents. So, once the asthma is established as poorly controlled asthma, there need to be emphasis on the daily preventer use, even if this child is going otherwise quite well in terms of the symptom control. But then we need to have a proper management plan from that point of view. That management plan emphasizes the number of times the inhaler needs to be used, also the number of times the preventer needs to be used. So both the combination of short acting beta agonist, which is salbutamol, and a preventer, which is Flixitide. And we need to redo the asthma action plan and give a very clear trigger of how that plan needs to be implemented, including the red flags which need to be highlighted. So in terms of the summary, sorry, I've just spilled my coffee all over the desktop. I need to clear this up. In terms of summary, we need to have an asthma which needs to be established. That's a poorly controlled asthma. How do we establish that? By frequent use of reliever with a poor technique and with a random technique, and frequent symptoms during the daytime, especially at school during the exercise induced activities, and at nighttime, frequently waking up. And then obviously we would establish that there is poor adherence and there's some technical issues around the compliance or the technique of using the inhaler. And then obviously they will need all of these points to be implemented in the new asthma action plan. So in terms of the checklist, what the examiner would be looking for is asking about the reliever. Um, that's what they would be marking you for, that you are asking about how many times are they using the reliever, how many times during the week are they waking up at nighttime. That is what would establish the control or adequacy of control of asthma symptoms. And then you are able to identify based on that onto the step two, as this asthma is inadequately controlled. And then you're able to emphasize the importance of a preventer as well as short acting beta agonist and educate on asthma. So that's how the whole scenario. It's a very common scenario, comes at lots of time. So this is very important that you know how to link the information. It's not just about saying what you know, it's about linking the information which is present in the scenario. Okay. All right. Just give me a second. I'll give you one uh, minute to read the scenario. Let me just clean my table up. All right, guys. Okay. So let me just uh, okay, I've just allowed the participant to unmute yourself. So if you want to unmute and ask any question related to the scenario, you can. All right. Okay. Dr. Divij. Okay. Hello, Dr. Divij. How are you? You might have to unmute yourself, Dr. Divij, maybe. Can't hear you. Sorry. All right. You might have to just have a look as to why your sound's not coming. I'll start with the scenario number 2 in the meantime. Okay. So look, scenario number 2 is all about this is the second pediatric scenario. This is about an 11-year-old girl who's brought into your clinic by her mother due to persistent cough for 3 months. This cough is loud and barking and notably dissipates when she's asleep. It has significantly impacted her school attendance and social life. So the tasks are: take a focus history from mother, 4 minutes. Well, sometimes, the AMC clinical scenarios could be time oriented. Explain your suspected diagnosis, 1 minute, and outline the management plan, which could be 3 minutes. Now, Dr. Divij has actually written all these scenarios. I've just modified them, but he is unable to talk for some reason. I'm not sure why. Um, and yeah, I can't really hear. Yeah. Anyway, so what would be the likely diagnosis and differential diagnosis? So I'm actually just going on to the most crucial part of the scenario as giving you the psychogenic cough, and I'll substantiate my claim. Why is it psychogenic cough or habit cough? Positive finding: it is a longer duration. It has got a barking quality. It disappears during sleep, and obviously, it's been impacting anything like that when it's going on. It will impact significantly on the quality of life. Now, one of the crucial thing is that there's no fever, there's no shortness of breath, there's no wheeze, there's no nasal symptoms, and there's no throat pain, which would indicate an acute illness like an upper respiratory tract infection or acute wheeze related to asthma or any crepitations which might be more indicative of a long-term infection. Some of these infections like viral infections, can sometimes go beyond a few weeks, but not often up to 3 months. What would be the other differential diagnosis? Vocal tic, which disappears in sleep, um, which could be stress related. Cough variant asthma is likely due to sleep disturbances, and nasal drip. We don't see that nasal drip, but sometimes it can be a main issue, but it does not vanish in sleep. In fact, it aggravates during the sleep because of the nasal drip. Now, I might just do a little test. Dr. Misha, I can see you on my screen. If you can mute yourself. And
Yes, hello, doctor.
yeah, I can see, I can hear you very clearly. So, have you got any ideas about how to take these tasks? I'll focus
You
history
mean the
from mother.
history taking?
Yes, yes. So these are the tasks like focus history
Mm-hmm.
from mother, explain your expected diagnosis, and outline the management plan. I was just interested, what would you be mainly interested in? So let's talk about um, the history component of it. I've already shared the differential diagnosis, but
Mm-hmm.
often, I say that it's not about knowing, but it's about proving what you know. It's about linking those crucial information lists.
Okay, I would ask about timing first. I would ask when did it start? Does it go on and off, or is it constant? Is it getting worse?
Hmm.
Um, uh, there's this CCVO mnemonic about what is this cough? Yeah, yeah, is it dry or wet? Um, if it's wet, is there any blood, mucus, or anything else? What's the amount of sputum? Is there any? Um, I would ask maybe if there were any trigger.
Hmm. Hmm.
Is there any fever and chills?
Yep.
Um,
Yep.
maybe any more flu-like symptoms like sore
Yep.
throat,
Yep.
uh,
Good.
nasal congestion.
Very good. So basically, in terms of the history, the focus is on three main things. And I'll read you those three main things. You're all right. But I think because the timing is crucial, the focus is to confirm that cough is only present once the patient is awake, not a nighttime cough. So that's very important.
Mhm.
Then you want to exclude an underlying organic pathology. Is there any underlying fever? Is there wheeze? Is there any other red flag symptoms of lethargy, poor oral intake, which would be associated with any intercurrent respiratory illnesses? And obviously, you want to make sure, because most of these psychogenic cough or behavioral coughs, there could be an underlying stressor. So if there's a stress, if there's any other issue which might be related to the education or family dynamics, so social history again becomes a very important component in this particular scenario. Now, people may not think about the social history, but then again, because it's a very important aspect of this scenario, you may have to take the social, and how much is it impacting the daily living of this child, and if there's any past medical history of asthma or any allergy exposure as well. So let's dissect this scenario a little bit further. So I've utilized this information in terms of differentiating various types of cough. So uh, honking cough, which disappears during sleep, it could be habitual or psychogenic, that what we are dealing with. Nocturnal, asthma. As we said, that there's a lot of mucus congestion that can give rise to asthma, wheeze related cough, because there's a bronchospasm which is worse at night because of the mucus plugging. Exercise related, again, asthma, cystic fibrosis, bronchiectasis with stridor, laryngeal obstruction. Obviously, that would be much more acute. The history won't be 3 months. Paroxysmal or spasmodic with inspiratory woof, pertussis. Now, pertussis is also known as 90-day cough sometimes. If you know, in Chinese proverb, it's a 90-day cough. It can go on for 3 months. Uh, Staccato, chlamydia pneumonia, that can also go for a long time. And then barking or brassy cough, croup, laryngitis, tracheitis, again, all quite acute, not long. And productive with purulent expectation and chronic bronchitis, cystic fibrosis, bronchiectasis. Again, these might be associated with intercurrent illness. Dr. Divij, can you hear me? I think you can, but I think your mic is probably not working. Otherwise, I would have loved to have his input during this scenario, because he's collected all the scenario, done a hard work. I've just polished them and presenting them. So, Dr. Divij, you haven't got any say in the matter. It looks like. So, okay. Okay, hang on. So I just wanted to draw your attention in terms of this very obvious picture. There's a stress factors which might be affecting the frontal cortex. They might be also triggering the motor and sensory part of the cortex, going on to the subcortex, and then all transcending down to the brainstem, where the main cough impulse is generated. And that is what's causing the cough. It's the stressor triggering the brain. It has got nothing to do with an organic pathology of the lung. It's brain triggering the brainstem, causing the cough and recurrent coughs. Okay. Next up, what would be the role player instruction? Now, this is very crucial, because obviously in this scenario, I say it's all about the diagnosis of exclusion. So we need to exclude the intercurrent illness, fever, wheeze, any other red flag symptoms, any other issues related to asthma, diagnosed or undiagnosed, any allergy issues which can present for a long time. That is also very important. So loud barking cough, that is what the role player actor would say. There's no associated fever, shortness of breath, post-nasal drip, nasal throat symptoms. There's no frequency, there's no association with exercise. And obviously, there would be some other issues surrounding the social aspects, which means social withdrawal. There would be some lack of attendance at school. And they would have tried everything, which means that any organically triggered cough would have responded to antihistamine if it's an allergy related. If it's related to asthma, it would have responded to bronchodilator, either a short-acting bronchodilator or long-acting bronchodilator or inhaled corticosteroids. And obviously, the most important component then becomes that mother is quite frustrated because she's tried everything and the child's still not getting better. So this is what would be the key aspect that you would need to touch on before establishing the diagnosis that it's a habit cough or a psychogenic cough, which is strongly supported by the fact that it resolves during night when the child is obviously asleep. Now, what would be the other aspect of the history that obviously we've talked about the night cough. We've talked about the characterization of the cough, that which Dr. Mishra was sharing, duration, sound pattern, triggers, whether it's got a wheeze, whether it's got crackles, whether it's productive, whether it's associated with fevers. And then again, we've talked about the psychosocial factors, and obviously the failed treatments is very important, because every time you're taking a failed treatment, the examiner is ticking off a box that you've touched base on that crucial aspect of asthma exclusion, antibiotic-related pneumonia exclusion, antihistamine-related allergy exclusion. Now, explaining the diagnosis is very important, because I think this scenario is almost 50-50, as was the previous scenario in terms of educating the parent. So he clearly explained that, look, you need not to worry about. It's something which does not sound like there's any red flag symptom of asthma or any long-term infection or any allergy component. It sounds more like a psychogenic or habit cough based on these three things, because it's only there when it's awake, there's no associated underlying infection, and there are some stresses which we should establish by that time by taking the history, social history, that is. And linked to diagnosis, obviously, I'm again re-emphasizing the same point over and over again, that the cough actually escapes or relieves during the nighttime, and reassure and validate mother's concern. I think Dr. Divij might be managing the chat box, which might be things. So if you would like to ask any question, he might be able to address that. And yeah, all right, okay. Now let's move on. So in terms of summary, we've talked about no organic signs. We've talked about complete resolution when the child is asleep. We've talked about significant social impact, limiting the activities. Then obviously the psychogenic or behavioral cough is the most likely diagnosis. And then checklist for passing, which is, again, I'd like to include that. I was recently doing the physical examination workshop here in Sydney. I like to make a little checklist at the end, which is a combination of all the history and all the task related key question, which must be there in order to pass a scenario. So again, a bit of repetition, but cough which resolves at night time during sleep. There's a trigger in terms of stress, and the role player will give you that trigger. And hence, the psychogenic cough will become a primary diagnosis. You are able to clearly explain to the mother and reassure that there is no organic pathology that would link your diagnosis to the stress related cough or a psychogenic cough. And then obviously the management would just not be reassuring, but also some other therapy like behavioral and psychosocial intervention. So GP referring to a child and adolescence psychiatrist, because there are stresses. They need to be a meeting with the parent in the school, like what kind of stresses, whatever the specific stressor. Could there be a family issue? Could there be school related issues in terms of exams, or in terms of, I mean, the child is too young to have exam related stress, but there could be some other bullying and harassment. So as the issue is, you need to intervene from that point of view. And obviously, you need to invite questions at the end. We'll do case scenario number 3, now moving into the adult cases. But before I do that, I'll just again unmute. I think everybody can unmute themselves and ask one or two questions regarding the previous scenario if they have.
Dr. Rizwan,
Yes.
this is Vishnu speaking. I just small doubt. In the history, is it necessary to ask about a school bullying or any psychogenic cause in the history to find out, to come to the correct diagnosis of psychogenic cough? Not only excluding rest of the diagnosis like asthma, aspergillosis, etc., but psychogenic school history, what is the main cause for the psychogenic stressor? Is it necessary to emphasize there in the history?
Yeah. So look, it's a very good question, and I think it's a very relevant question for this particular scenario. I would say yes, and there are two key aspects in the history which need to be established from the stress point of view. So the stress could be domestic stress. The stress could be related to school. The stress could also be related to some other surrounding where the child is involved. It could be, some sort of play area or play group, some sort of sports activity that the child does outside the home environment and the school environment. And how do you establish that? By asking the particular question. So I know and I can understand that it might be limited time to go and individually ask about how things are at school, how things are at home, or how things are at any other environment where the child might be engaged in terms of sports or any other thing. Or you can say, is there any stress or anything in particular that you may think that child might be bothered about, or Sarah might be bothered about, either at school, sports, or at home front? But just by mentioning one sentence, actor would be programmed to volunteer that information. They can no longer withhold that information because you touched on that. Because if you don't touch on that, they won't.
Thank you, Dr. Rizwan.
Okay, we'll move on to the next scenario, but that was a very good question, Dr. Vish. All right. Now, this is a very important scenario. This has been asked a number of times in the recent recalls this year, at least 3 times in this year clinical exam. Again, thanks to Dr. David Sharma for making these clinical scenarios. So this is Mr. Robert Davies. He's a 67-year-old man presenting with numbness and tingling in both feet and lower legs for last 6 to 8 months. Symptoms started in the toes and progressed up to the mid-shin. He feels like pins and needles or dead sensation in his lower limbs. They are worse at night, and sometimes it even disturbs the sleep. There's some slight unsteadiness in, I think I would want to say, gait in dark, because he's not been able to get that proprioception input. That's what I mean. No severe pain, weakness, or bowel bladder symptoms. He has got type 2 diabetes for the last 10 years, and he's currently on metformin. And he's concerned about his symptoms worsening. You need to take the history, come up with the most likely diagnosis and reasonable list of differentials, and outline the short and long-term management plan. So here's the likely diagnosis. Most likely diagnosis, sensory neuropathy, owing to the poor control of diabetes. Obviously, if the scenario is giving you the history of diabetes, then you need to factor that in with the peripheral neuropathy. Why? Because there's chronic 6 to 8 months, symmetrical, both lower legs, and distal to proximal progression, which is typical of diabetic neuropathy. It's often worst at night, which keeps the patient awake because it's an uncomfortable feeling, even though not painful. Diabetic neuropathy is not painful, but it's uncomfortable. And then there's a diabetes history. So when you're talking to the role player, again would be programmed to tell you that my diabetic control is not good. He may tell you that I am waiting an appointment with an endocrinologist because my diabetic control has been poor. So you have to touch base with all that macrovascular and microvascular complication of diabetes. The other differential, which is very important, apart from the diabetic peripheral neuropathy, would be vitamin B12 deficiency and alcohol-related neuropathy. Now, this is very important, guys. Often you would be reassured by the fact that this patient is diabetic and he's got peripheral neuropathy, but there could be a coexistent alcohol intake. So always do check up on alcohol. Okay. So let's go on and explore further. So role player instruction, what would the actor be programmed to say? So obviously he would reaffirm the symptoms have been there for 6 to 8 months, mainly pins and needles or numbness and tingling, distal to proximal progression, dead feeling in the legs, obviously interferes with the walking, sleep, and especially in the dark. This is a typical sign of diabetic neuropathy because the patients are reliant on their visual symptoms or vision to walk. That proprioception, which is a part of the sensory input, proprioception means the sense of positioning of the joint. That proprioception sense is no longer working. So that is the most crucial aspect to establish. And obviously, there's a history of diabetes, and only when asked, the actor will then volunteer the information that he has been an alcoholic for a long time and still drinks 4 to 5 beers a day. And obviously, there's an emotional concern, which we often ignore, but it's very important because he's at risk of having a fall and he needs to have this sorted out. So, again, as I said, task-oriented approach. The first task is to take the history. So, what would be the crucial factors in history? That you need to clarify the onset of history. What is the distribution? What we call the glove and stocking pattern. What has been the progression? You need to also assess for the systemic causes, like as I said, diabetes, alcohol, renal, thyroid, any other autoimmune conditions. So all of this come through the history, progress on from the history of present complaint, history of present illness, past medical relevant history, and social history, as I said, becomes very important here as well. And always it's important to review the medications in the family history and again, occupational exposure as well. Okay. You also need to, explore, because it's not just about establishing the facts, but also the quality of life which is been compromised. So again, his balance issues, he's at risk of falls, he might be living alone, he's obviously not sleeping well, so daytime somnolence, and there might be bladder and bowel symptoms as well, which are associated with diabetes. So what is the second issue, which is the explanation towards the diagnosis, the key diagnosis, which is diabetic neuropathy, because it's chronic, it's symmetrical, it's distal to proximal, walking worse at night because the patient is reliant on his sensory vision input. And the other differential, which we've already talked about, is alcohol, which is the most strong contender here. Management, very crucial, very important, because I think the management would be 50-50 if it's plugged into this scenario, the short-term management and long-term management. Then neuropathic pain meds. Now, obviously, if he is saying pain, then you need to talk about a specific pain management. It's not no longer about Panadol and Nurofen. It's all about neuropathic pain medication, which is like gabapentin or amitriptyline if there's no contraindication. You need to also give him safety advice that do not walk in dark unaided, have the lights turned on. So that's very important. Also, you need to say that you need to establish the gravity of situation, because as much as you like to say and tell him that it's all diabetic neuropathy, which it might be, but as a good doctor, your job is also to exclude any other form of peripheral neuropathy. And how do you do that? By doing nerve conduction studies, and myographic studies. What if it's some sort of myopathy? What if it's some sort of other peripheral neuropathy? And what is the long-term management? You need to treat the underlying cause must you establish, which obviously in this case would come out to be diabetes. There needs to be lifestyle changes. There needs to be foot care with the podiatrist. There need to be a regular follow-up with the physiotherapist in terms of improving the muscle group strength, OT in terms of equipment, and patient education. So I often say that, look, AMC is more about specifics. It's not about generic throwing it out there. Whenever I go and practice scenarios with the AMC participant, they just put the information there without any linking of the information. You need to first, as I said, gather the information and then give them information linking what you've gathered. You can't just, put it out there that, oh, you need physiotherapy, OT, and patient education because of the more, you're not really established anything. I can understand what you want to put in a short span of time, but again, linking is very important. Key learning points: symptom distribution, length dependent sensory neuropathy. Diabetes is the commonest cause. Alcohol and B12 are also relevant. Neurohistory is very relevant, and management is largely symptomatic and obviously having a better control. He might be in metformin, which is not controlling his glycemic control. So after doing the proper investigation like HbA1c, and you've established that, there might be an examination scenario in which one of the examination scenario, in fact, that was the case, that his HbA1c is 12.7%, which clearly shows you in the last 3 weeks his diabetic or glycemic control has been very poor despite being on metformin or any other diabetic medication. Okay, moving on. So checklist for passing, which will get you in hot water, is that duration and pattern and progression of his symptoms. Obviously, you need to establish the diabetic sensory neuropathy as a most likely diagnosis only after establishing that he's got a poor control of his diabetes. His blood sugar levels are still high. He's waiting to see endocrinologist. The GP is not currently happy with his management plan. You need to then order, when you're giving him a management plan, incorporate these investigations that, look, we'll order the HbA1c, B12, TFTs, and nerve conduction studies to cover other bases as well. And in the meantime, while you're waiting to do that, how about we educate you in terms of how to walk about, how to make sure that you're carrying on yourself safely. Will involve the physio from the mobility point of view, OT from the mobility aids point of view. And you need to be very empathetic during all of that. So I'll just take a pause here if anybody's got any questions related to this scenario. Okay, we'll move on. So clinical scenario number 4. This is a very interesting scenario because these kind of patients you don't commonly see in clinical practice. However, they are still a substantial part of AMC clinical recall. Why we don't see them? Because they're very well managed out in the community. So Miss Alex Sharma is a 20-year-old male, 1 week post-splenectomy for a chronic blood condition. He's here for a follow-up appointment and is feeling tired but otherwise well. There are no signs of infection at wound site. There's mild discomfort, which has been reported. Patient is anxious about living without a spleen and seeks practical advice. So I think this scenario cannot be more black and white, what's already been mentioned here. Your tasks are to counsel the patient about post-splenectomy do's and don'ts, and explain about the possible complication and essential vaccinations. So again, very bread and butter scenario. I think most of you would know how to handle this situation. So let's go into it. So obviously, no prize for guessing this one. This is a post-splenectomy state, the major concern of which is overwhelming post-splenectomy systemic infection, which is also known as OPSI. Obviously, the patient is not in OPSI right now. He's a post-operative patient. He's only concerned about some of the short-term and long-term complications. So we need to not only counsel him from an immediate post-operative complications point of view, but a long-term complication which could arrive because of lack of spleen, and what vaccination does he need to have. So general post-op complication, DVT, wound infection, ILS, obviously with any abdominal surgery, ILS is a real problem. Underlying blood condition, because obviously if he has had the spleen removed because of the high hemolysis, could be any of the hemolytic anemias, then there could be a relapse or worsening of that condition. So he needs to be in our hematologic follow-up. And risk of OPSI, which can cause life-threatening bacterial infection, which is perhaps the most important point. So in terms of key advice, the do's and don'ts, remember that the scenario is all about, if you look at it, counsel about post-splenectomy do's and don'ts. So what are the do's? Here we've already talked about post-op complications, do's vaccination, and we talked about vaccination. I'll show you then on the next slide what vaccinations. And obviously, don'ts are avoiding any high-risk activity which could potentially harm the patient to a life-threatening infection and some animal bites. So let's have a look. So this is a very important, and I think this is a very simplistic chart. And this is what highlights what could lead to overwhelming post-splenectomy infection or OPSI. So they're all capsulated organism. Streptococcus pneumoniae is the most common one. Haemophilus, Neisseria meningitis, Streptococcus species Salmonella, and Capnocytophaga canimosa, that is due to the dog bites. What would be the features? Obviously, this scenario is for a well patient, but obviously, if there's a scenario related to a post-splenectomy patient who looks unwell, there could be some prodromal features like fever, chills, non-specific sore throat, and diarrhea. Rapid progression to shock state, which would be coupled with DIC, hypotension, high-grade bacteremia, fevers, rigors, chills, and poor response to antibiotics, because these patients do have a tendency to go into septic shock as their immune system is compromised. There's virtually no spleen to capture those encapsulated bacteria, which we've listed here: Streptococcus, Haemophilus, Neisseria, and Salmonella. Okay, so prophylaxis, which is elective and emergency. Elective at least 2 weeks pre-operatively, pneumococcal vaccine. Children under 2 years, pneumococcal polyvalent vaccine, Haemophilus vaccine, and meningococcal vaccine. And then emergency, obviously, if there's an exposure, immediate post-operative period, pneumococcal vaccine and pneumococcal polyvalent 7-valent vaccine, and Haemophilus at least 2 weeks post-operatively, Haemophilus vaccine and meningococcal vaccine. Okay, so this is just a journal outlay about how to address this situation in terms of vaccination. Now, if we've known about that, that's fine. And so the patient may have presented in a scenario with a dog bite. So when your dog bite, then you're worried about Capnocytophaga canimorosis, especially if scratched or bitten by a dog, because that is also an encapsulated bacterium which can not be now filtered out because there's no spleen, and that can lead to OPSI. Okay, also some parasitic infection are there like malaria and babesiosis. Okay, so role player, what would the role player be? This patient is not sick. This patient is only in the post-operative period. So he will say that, look, I'm just feeling generally well. There's obviously some pain related to the operation at the operation site. However, I'm not unwell with any fever. There's no redness in the wound, which which make you think that like there's early cellulitis. He's obviously would be anxious because his spleen has been taken out and he's heard or read about it in the media or on some information booklet. Ask about the lifestyle risk, vaccination, and future health issues, and wants to know about staying safe, and will initiate question if unprompted. The patient will also initiate question if you're not addressing his concerns. So do's and don'ts we've talked about. Now these are more do's and don'ts early on in terms of post-operative issues like avoid lifting. I mean, sometimes you may see that post-splenectomy patient may completely lose the track about it is a post-operative period. You would take into context that it's a fresh wound. It might be a big, large laparotomy wound. If he's lifting off heavy weights, doing some gymming or sports, it may cause wound complication, dehiscence, hernias, and all that kind of nasty complications. Wound needs to be kept clean. And if there's any redness or discharge or pus, then obviously these are the signs of infection. And obviously need to have a very strict hygiene, especially hand hygiene and dressing hygiene needs to be adequately changed as per advice from the surgeon. And most of these patients would have a bracelet, which would say that they have got no spleen or they are asplenic. Okay. All right. Next up, we've talked about that high risk, rapidly progressive, and life-threatening infection with OPSI. And obviously, if the patient is showing all those constitutional and specific signs, being feeling ungenerally unwell, rigors and chills and fever, then you need to take the patient or send the patient immediately to emergency. That's where your job ends. If you're in a GP clinic, send the patient to emergency, make a phone call to the emergency admitting officer. I'm sending a patient who has got no spleen and has come generally unwell. And I think that he might be progressing towards the overwhelming post-splenectomy bacterial infection. And when you talk about vaccine, pneumococcal and meningococcal and Hib vaccine are by far the most important. If you want to remember any vaccination, please remember these three vaccination: PMH, past medical history. Easy to remember. Okay. Timing ideally pre-op or at least 2 weeks post-op, and boosters would be needed periodically. Okay. So again, summary-wise, asplenic, generally well, stable, post-op infection, post-op wound care, preventing of localized infection, and obviously concern about overwhelming post-splenectomy infection, then talking about the vaccination. I think it's relatively simple and self-explanatory. If you got any question, you can unmute yourself and ask question. Otherwise, we'll extend on to the last and final scenario, which is very important. And it's been asked almost every time in AMC clinical exam. Any questions, guys?
Dr. Rizwan, you are doing great job. It's a really nice direction and nice outlook, and you are following the proper format and proper planning.
Thank you very much. I appreciate it because it comes out of the need.
Sir, I can see I have done so many OSCEs in America and Canada. So you are following the same format what we are following in America and Canada. That is a OCD, PQRST, AAA, and then past medical history. Then past medical history contains surgical history, medical history, then SAD, smoking, alcohol, drugs, and reactions, then social history, then further collaborating the diagnosis, and as far as the ruling out the differential diagnosis and associated symptom also. You're doing the same thing.
And if you do that,
Excellent, sir.
I kid you not, it would be difficult to fail the AMC clinical scenario because you've not missed anything crucial. We need to be very specific and we need to be able to extract the information. Anyway, thank you very much. Let's jump into the last scenario.
Thank you, sir.
You're welcome, sir. You're welcome. Okay. So just before we jump into the last scenario, in terms of checklist, passing covers OPSI. Obviously, it's very important. Cover all key vaccines. If you're not able to cover all key vaccines, at least talk about the key vaccines in terms of PMH, pneumococcal, meningitis, and Hib. Lifestyle guidance, keeping clean, maintaining basic hygiene, and obviously, guys, be very clear and empathetic. And engages and checks patients, understand everything. Dr. Divij, have you got any input? I'm not sure if your mic is working right now or not working. No, it's still not working. Okay. That's okay. That's all right. Maybe next time. Dr. Divij is going to be working, doing AMC clinical scenario. He's a very diligent guy, and it's shame that the mic is not working, but I'm sure that he has plenty to add on when he does the high yield clinical scenario, which we're starting September, isn't it right, Dr. Divij? Yes, we're starting September. The high. So basically, what we're doing is we are doing clinical case scenarios, high yield ones, It'll be a 7-day boot camp, and exactly in the same format, in which Dr. Divij would have extracted all the key recalls, AMC clinical recalls for the last 6 months. I think up to 6 months would be a reasonable time frame, and then we'll be breaking them down exactly like that. So if you're approaching the exam, or if you want to pace yourself for the exam, then that would be a good boot camp to attend. Anyway, let's jump right into the last scenario. Times of the essence. I really appreciate all of you making time on this Sunday. So 46-year-old female presents with severe headaches and generalized weakness for 6 weeks. She has past diagnosis of giant cell arteritis and is on 20 milligrams of prednisolone daily. Now, tasks are to take a focus history of presenting complaint and systemic symptoms and request a specific physical examination findings from the examiner and provide the most likely diagnosis and relevant differentials. Now, this scenario is very important because of the fact that we get these kind of patients routinely in emergency department. It's very high frequency case, I think, mainly because of that reason. Anyway, let's dissect that again. We need to cover off initially putting our mind into that framework. The most likely diagnosis, as you all know, would be the concerns about the giant cell arteritis. The differential diagnosis would be steroid-induced myopathy or any steroid-related side effects, or PMR, or polymyalgia rheumatica, and opportunistic infection due to immunosuppression. Because I mean, she's got severe headache, weakness, she's on steroids. Could this be meningitis? Could it be encephalitis? I think it would be a blunder not to cover these crucial differential diagnoses when you're talking about a headache in a relatively young female who is on immunosuppressive or immune modulators. So just a very quick, I like figures from the point of view because they cover a picture as well as 1,000 words. So inflammation of the wall of the temporal arteries. Because of that inflammation, it can cause vision loss, which could be permanent, and it's an emergency situation. That's why when they come to emergency, there's a very low threshold in terms of giving them IV methylpred or methylprednisolone. It also increases risk of stroke and heart attack because it is an arteritis, it is an autoimmune condition. And one of the key feature is jaw claudication, which you get, pain on palpation over the temporal artery, pain on chewing, pain on brush hairing, and all that kind of thing. Associated with that is fever, fatigue, unintended weight loss, joint and muscle ache, which why is that important? Because it highlights it's an autoimmune condition and it's multi-system. So don't be, focused on just head and face kind of symptoms. It's a multi-symptoms, joint, muscles, they would all be affected, and there's some lethargy and this fever. So whenever you talk about any autoimmune condition, guys, just keep in your mind fever, lethargy, and joint aches and pains are like a gold standard for any autoimmune condition, be it rheumatic fever, be it giant cell arteritis, be it for any other autoimmune condition. Now, I like this figure. It shows very prominent temporal vessels, and this is a cross section because the gold standard is, histopathology of the temporal artery, and you can see all that inflamed temporal artery. And this is the giant cell, I think it is. I'll highlight it better in the next figure. So just to this visual representation is if you see a patient, or if there's an exam card with that kind of patient, then basically what you're looking at the cross section of the artery is that giant cell inside the lumen or at the boundary of the lumen. So this is how it looks like. This is the internal elastic lamina, and there's a giant cells within that lamina. And there's, you can see the lots of lymphocytes. Okay. Obviously, they won't show you this cross-sectional slide because I've just made it a bit more visually appealing for you guys. So anyway, what would the role player be instructed to respond to your specific question? Gathering information, giving information. So she would be in the range of 40 and 50s. That is the peak incidence of giant cell arteritis. She would be on a maintenance therapy. She would be presenting with bilateral temporal headaches and scalp tenderness. And scalp tenderness, obviously, you can establish by brushing hair, touching yourself on the scalp. Jaw claudication, blurred vision should ring red flags or ring bells. There'd be fatigue and weakness, and occasional night sweats and weight loss, concern about relapse and vision loss. And then obviously the patient would be anxious wanting to know about what's going wrong, as any other patient would be genuinely concerned. So task-oriented approach, there's a history component. So we need to establish everything about the headache, from the nasty headache to a benign headache, about the location of the headache, severity, duration, associated symptoms. Obviously, if the fever and headache, it's very difficult to dodge encephalitis and meningitis, which would be a very strong differential for this kind of headache. But then again, what drives this patient or makes the scenario sounding more like a temporal arteritis would be that specific scalp tenderness, visual changes, jaw claudication. That is specific information that you need to establish to move away from that meningitis, encephalitis, and other forms of cervical or referred pain headaches, and plus the fact that the patient is on prednisone. Compliance might be affected, which may suggest the patient's got a relapse, and that's what happens sometimes when I see these kind of patients. They would be on the tapering dose of the prednisolone, and then they would get a relapse. So ask not only about what dose they're taking, if they've reduced the dose either drastically or suddenly, or if their dose has been reduced by their immunologist for some reason. Impact on daily life, obviously, is very important from every scenario point of view. Task two, obviously, this is a scenario in which you'd be extracting the information from the examiner. So you'd be asking very specific information, because it only be 30 seconds to about a minute. Like, is there thickness or tenderness or pulsations over the scalp, over specifically in the temporal area? The examiner says yes. So you have to ask these questions to be replied positively or negatively. And what about the visual assessment? They'll say, oh, vision is 6/24 on the right eye, or 6/18 in the right eye. What about the acuity? What about the fundoscopy and ocular movement? And they will respond appropriately. And ask, obviously, because it's a headache or neurologic condition, ask about the key general physical findings in terms of vitals, especially the temperature, and neurologic examination if there's any stroke type symptoms in terms of slurred speech. Because if there's vision upset, then you would also be worried about the stroke or occipital stroke. You'd also be worried about other key stroke findings in terms of MCA territory. So that would be the strong differential. If you'd ask me, the two key differential in this thing would be stroke or variancy of stroke, and meningitis and encephalitis. And obviously the three working diagnosis would be the relapse of the temporal arteritis. If you are not basing this scenario on these three differential diagnoses, then it's not going to go well. Obviously, when you're explaining to the patient, which is a task 3, you need to sound very empathetic that, look, you've done the right thing, you've come to the hospital, and I'm afraid that it looks like it could be a relapse or recurrence of your giant cell arteritis. Give them time, pause, let them assimilate this information, and then go and explaining that the reason I suspect that is the case is because you got headache, which is tender over the area of that temporal artery. You got vision symptoms, because of the blood supply from the temporal artery supplies the key part of the visual cortex and the eyes. And obviously, there's an underlying diagnosis of giant cell or temporal arteritis. And this is all justified based on the history examination and treatment courses. Finally, this is a bit of a summary in terms of what does that all mean? It means that the patient needs high-dose steroids, which I said earlier, that these patients would often get IV methylprednisolone. You don't have to remember the dosage, but just remember that you need high-dose steroids and you need to be admitted in the hospital. So key learning point, as I said, it's all about information gathering and information giving and linking the two. Recognize relapse in the treated GCA, either by the dose reduction, lack of compliance, or any other flare-up. Could be any other reason which was beyond the scope of this scenario. Red flag symptoms, visual changes, scalp tenderness, which are linking the relapse of GCA. Again, exclusion of meningitis, encephalitis, stroke type symptoms. What it means, linking the information, high-dose corticosteroids, and clearly communicating the patient, that is the need that I need to admit you to the hospital. That is the need that you need to be admitted under immunologist, and this is how we're going to treat you and monitor you. So often patients would say that you need to be admitted under neurologist. No, these patients are not admitted under neurologist. They are admitted under rheumatologists. Yes, that's right. Rheumatologists or immunologists. Okay. Checklist, elicit key red flags. We've talked about vision, jaw, and scalp tenderness. So that's important. Targeted physical exam, the information that you're extracting. It's almost like guessing the right animal. when it comes to that. So you're asking for the temporal artery tenderness, you're asking about the vision loss, you're asking about the jaw claudication, and then you need to immediately safety net and talk about the management aspect. Sometimes the patient may ask you that, look, how do you know? How can you be sure? You say that often, it's a clinical diagnosis. However, it can be confirmed with the histopathological diagnosis. Often that takes time. And the concern right now is that we don't act now in terms of giving you a high dose steroid. You may lose your vision permanently. The diagnosis, which is established by histopathology, may take days to come back. And that's about it, guys. Thank you very much for attending. And if there's any question related to the scenario, I'm more than happy to take the questions at this stage.
Thank you, sir. Thank you very much, sir.
Not a problem. Appreciate it. Thank you, guys. Thank you very much.
Dr.
And
I got one small doubt, Dr. Sir.
please clear your doubts.
How can I ask clarification for a patient while taking the history?
So so you can say a very specific question that when you're chewing, because when you're chewing, you're squeezing your temporalis muscle. It is
Yes.
one of that. So when you're chewing, you get this jaw pain or jaw claudication. So that could be the specific question. Have you noticed anything differently about when you're chewing your food? Have you noticed anything differently, especially when you're opening your mouth or yawning? Have you noticed anything differently when you're combing your hair? Have you noticed anything differently about your vision? So I think it's more of all these three factors: jaw claudication, vision changes, and then again the general non-specific factors of weight loss and fever and low-grade fevers and generalized body aches. And the patient's already got established diagnosis of giant cell arteritis. Oh, sorry. Previous rheumatological condition. The giant cell arteritis, a relapse as a complication of that rheumatological condition.
Thank you, Dr. Rizwan.
No problem, sir. Thank you very much. And look, guys, study well and make sure that you stick to the specific. AMC clinical is a very easy exam if you know how to address the specific. If you are not sure how to address the specific and you want to practice more scenario, join our boot camp, which will be starting in September. Dr. David Sharma, who was here just a short while ago, unfortunately, for some technical glitch, his mic did not work. He would be assisting. He had written all these scenarios. You can see the hard work behind that. I hope it all goes well. Those of you who are taking your exam, all the best. And those of you thinking to take the exam, do study well, study hard, but practical study should take emphasis. Thank you very much. Okay.
Thank you,
Bye,
Dr.
guys.